7. The title is Health and Social Protection. It is a time-worthy and cross-cutting, multifaceted issue. We all know that health and social protection in Bangladesh has been the area of focus for over a decade and more than decades. The government, along with various international organizations, has been working to provide social protection to vulnerable population for decades. We know that social protection encompasses a range of policies and initiatives aimed at elevating poverty and vulnerability. This is all well known, but some such initiative that has taken by the government of Bangladesh, we all already know that, for example, we can cite the example of the health protection scheme known locally as Shastro Surakha Karmasuchi, which is in short SSK, led by Health Economics Unit, Ministry of Health and Family Welfare. The primary objective of this SSK is to stimulate the use of health facilities, increasing the treatment of insured diseases within the poor population of the pilot region. It is a major step towards achieving UHC in Bangladesh. So we are going to hear 4 papers on this issue, which is related again. I'm repeating the title, Health and Social Protection. So we have 4 papers. There is a housekeeping rule. All the presenters have, each presenters have 10 minutes to present their papers. So I'd like to first introduce, request Mrs. Faiza Shehrin, a student of Jahangirnagar University, to present her paper. The title of her paper is there a Kuzet curve for the burden of non-communicable diseases and investigation in South Asia? Faiza.
Good afternoon, everyone. I'm Faiza Shehrin, currently studying in Department of Economics, Jahangirnagar University. Today, I'll be discussing a paper which is about, is there a Kuznets curve for the burden of non-communicable diseases and investigation in South Asia? In this paper, other co-authors are Anindo Boral Orko and Samil Sakib. Both are the student of Department of Economics, Jahangirnagar University, and Istiak Raihan Shubho, lecturer of Department of Economics, Jahangirnagar University. Well, economic growth is a dynamic concept with far-reaching implications for individual, society, and global landscape. Post-colonial era, South Asian countries has grown significantly as rising star of global economy for its effort to reduce poverty by developing their education, business opportunities, infrastructure, and increase in export, making South Asian countries one of the fastest growing economy in the world. Each South Asian countries has its unique trajectory. Like India, which is the regional giant, is projected to be one of the major global leaders. And Bangladesh is doing an impressive job with its booming garments industry. Pakistan, who have progressed, and Nepal, Sri Lanka, Maldives, Bhutan, those countries are doing very well in their tourism sector. So it is certainly important that countries should develop economically, but ultimately its true meta lies in its implication on people's life. So we see a rising trend of NCD burdens globally, and some regions it is very crucial. So in this paper, we will discuss NCD burden and its economic impact. So first of all, we should know what NCDs are. So diseases which needs long-term treatment and intensive care are NCDs, such as cardiovascular disease, cancer disease, respiratory disease, diabetes. You guys will be shocked to hear that every year over 40 million people die to NCDs all over the world, and which is equivalent to 74% of global deaths. Additionally, 17 million people die prematurely before reaching 70 years old, which makes NCD not only a threat for older people, rather a global threat for all. And while making SDG framing, NCD is identified as a as an indicator, as an obstacle for achieving global sustainability and setting target SDG 3.4 to prevent this global threat. Now let's look at some data here. This data shows the burden of disease by cause globally for 1919 and 2019. Here in the blue bars represent the communicable disease burden and blue bars represent the non-communicable disease burden and red bars represent the disease burden for threat. But if we look at the data for 2019, it is clear that non-communicable diseases are rising over the years. Same trend is evident for the disease burden of South Asia. So it can be concluded that NCDs are not only rising globally, but it is rising both globally and regionally, which is demanding an urgent attention and need for public health policies. So as we see, one side economy is growing and another side non-communicable disease burden are growing. So here a question arises, does economic growth really increase non-communicable diseases? So in this paper, our main objective is to study this relationship between economic growth and the burden of non-communicable disease by using Kuznets curve framework for South Asian countries. So for this analysis purpose here, we use three theoretical framework. First of all, we use Kuznets curve framework, which shows the nonlinear relationship between economic growth and inequality. Then we used environmental Kuznets curve framework, which shows a nonlinear relationship between economic growth and environmental degradation. And lastly, the main concept of our paper, which is health Kuznets curve. It shows the nonlinear relationship between economic growth and disease burden. As we see, when economic grow, environment also degrade in the environmental Kuznets curve, and later environment eventually environmental quality eventually increase. So from this we can also say that as environment quality and NCDs are linked. So that for his health Kuznets curve, economic growth, even if economic growth first increase communicable disease burden, it will later decrease. Now let's look at the literature review part. Here for the literature review, we focused mainly on the relationship between economic growth and major NCDs. For cardiovascular disease and diabetes, there is evidence for of finding inverted U-shaped relationship with economic growth. And for another NCD, obesity, there is obesity Kuznets curve valid for some countries, but a contradictory finding says there is no rate of obesity prevalence decreasing in higher income levels. Then the next NCD we incorporated in our literature review is cancer incident, which increased sharply with per capita income, but there is no evidence of inverted U-shaped relationship between economic growth and cancer incident. And lastly, the factor we used in our literature review, which is tobacco consumption. There is a Kuznets curve for tobacco consumption, which says economic growth has dual impact on tobacco consumption. First, increasing due to factors like increased affordability, then decrease as people become more health conscious and changes in social norms. So as we see, there exists some research which focus relationship between individual economic growth and individual NCDs, but enough research are not found on the total NCD burden and economic growth, especially in South Asian region, and non-linear relationship between total burden of disease and economic growth remain unexplored. So to fill this gap, we evaluate this relationship in our paper. For the study purpose here, we used variables such as total burden of disease, which is DALI here. And then we use real GDP per capita, square of real GDP per capita, environmental degradation. For environmental degradation, we use carbon dioxide emission. Then we use urbanization and smoking prevalence. And here, all of the data are collected from global disease burden World Development Indicator, and our World in Data. So here we used a balanced panel data set for 7 South Asian countries to quantify the relationship between dependent and independent variables. First, we used fixed effect and random effect model. Then we used Hofmann test and some diagnostic tests such as heteroscedasticity test, cross-sectional dependence test, and autocorrelation. In this table, our result of fixed effect model and random effect model is shown, in which we can see that real GDP per capita, score of real GDP per capita, urbanization, and carbon dioxide is significant in both of the models, and smoking prevalence is insignificant in this model. And then the result of Hofmann test, here we see it claims that random effect model is better suitable for our data. And then for diagnostic test, first we here the table shows the panel heteroscedasticity for random effects. Here we use Bruce-Pagan LM test, which says that our residual error terms has heteroscedasticity variance. Then for cross-sectional dependence, we used 2 tests. First, we used Bruce-Pagan LM test of independence, then PCR and CD test. And both of the tests confirms that there is cross-sectional dependence in our residuals. And lastly, the result of autocorrelation test confirms there is autocorrelation. So as we see, our data has autocorrelation, heteroscedasticity, and cross-sectional dependence. We cannot use the random effect model as it can produce a biased estimate. So here to overcome this issue, we use fixed FGLS model. So the result of FGLS model here shown in this slide. We can see that real GDP and its square term both are significant, and urbanization and carbon dioxide emission also significant in this model, and smoking prevalence is insignificant in our model. So let's discuss the findings of our paper. As we see in FGLS model, GDP and its square term both are significant, and square GDP is negatively related with our dependent variable. It supports the validity of Kuznets curve for the burden of non-communicable disease, which reflects when economic growth, it may increase the burden of NCDs as the environment pollutes often then, and environmental pollution triggers NCDs. And later, when economy grow further, people will be conscious for their health, and their facilities for education, better healthcare access will be provided. So the burden of non-communicable diseases will eventually decline then. And our additional finding says that urbanization improves health outcome, and the can I get 2 more minutes, please? Okay. Then our additional finding, which is carbon dioxide emission is significant, and it says if environmental pollution increase, it will increase our NCD burden. And lastly, we can say these dominant variables might have overshadowed our result. So for this, the smoking prevalence might have found insignificant in our model. So lastly, we are almost at the edge of our discussion. Now let's share some thoughts and policies for our paper. Our paper suggests that economic growth should be sustainable and planned. Here we see that there is our data supports Kuznets curve, which actually actually present a point beyond which disease burden will decrease. So our paper recommend a sustainable and planned economic growth for further decline in city burden, and urbanization should be planned. And lastly, our paper recommend that effective policy for reducing carbon dioxide emission or increasing environmental quality should be taken. So that was all my discussion. Thank you, everyone.
Thank you, Faiza, for your presentation. It was an excellent presentation. I now request our second presenter, Shomojit Rai, research analyst, International Food Policy Research Institute, New Delhi, India.
Thank you, ma'am. Thank you, Madam Chair. So today I'll be talking about impact evaluation that we did for one of the newest maternal cash transfer program that India is currently undertaking. Before I talk about why did we do this, I just want to talk a little bit about cash transfer program. I know everybody in this room is aware of what cash transfer program is. Recent systematic reviews have shown that close to 1 billion people in 186 countries are receiving one or other form of cash transfer program. And in India, we have had a rich history of undertaking some sort of a social protection program, cash transfers being one. So the very first cash transfer, maternal cash transfer program that Government of India took was in 2005. It's called Janani Suraksha Yojana, JSY, to promote institutional delivery so that pregnant women can go to health centers and deliver their babies. The program that I'm going to talk about is the next generation of cash transfer program, which Government of India launched in 2017. So that's the basic motivation of why we wanted to understand what happened after the program. But before I do that, let me just quickly talk a bit give you an overview of the program, because I'm sure not many of you are aware of it. So the program was launched in 2017. It's a pan-India program, so all eligible people in the country can get a sum of Indian rupees 5,000. By eligible, what we mean is anybody who is having their first child can approach the government and get a 5,000 rupees. This 5,000 Indian rupees is disbursed into 3 tranches. So the first 1,000 rupees you get when you register your pregnancy. The next 2,000 you get when you undergo 180, you go ANC, that is go one ANC, and then the last 2,000 you get after successfully delivering a child and going through first round of immunization, child immunization. And if you want to understand how the program is structured, so both the central government and the state governments are working together to implement the program. So at the center, the Women Child Development, MWCD, is the one which is implementing the program, but the states have the option to either use the health department or the WCD or the social justice department to implement this program. So I'll talk about the research questions that we have. So we are calling it 3 E's. The very first, the first E of our 3 E's is effectiveness. So what we are trying to see is how is this program impacting anthropometric outcomes? So some of you who don't know, I'll talk a bit about anthropometric outcome. So the first research question is how the potential beneficiaries of PMMVY compared to non-beneficiaries do on the anthropometric outcomes. The next question that we are looking is what are the pathways through which, even if there is an impact on the anthropometric outcome, what are the pathways through which probably this program is working? That is the effectiveness. The next question, the research question, the RQ3 that we have worked on is the efficiency. So what we want to understand, and that's actually one of the biggest questions that government and policymakers often ask is, even if you are spending the money, what is the efficiency of it? How much reduction or what reduction does it cause on the key outcomes that the government is working on? So this question is very pertinent to that. We want to understand what's the association between government spending and the anthropometric outcome, reduction in anthropometric outcomes that we see. Lastly, this is last question, the last RQ and the last E of our research question is economics. So we want to see is this program cost effective? Is this even viable for government to undertake? I'll quickly go over the data. So we have used a DHS or NFH. In India, we call it NFHS, National Family Health Survey. In Bangladesh, it's called DHS. In some of the other countries also, it's called DHS. So DHS is there. We have used some administrative data, so data from Indian Parliament, HMIS, and census. Evidence. So what I want to talk about is, so what you see here is the graph on the where you have the red dotted bars. What it shows is, so the program was started in 2017. The round NFHS 4 took place in 2015, and we also have NFHS that happened in 2017. So between the 2 rounds of DHS or NFHS, we see that there is a substantial portion, close to 19% of beneficiaries who report that they have received at least 5,000 or more, right? And these are firstborn. So as you remember, the program was targeting the first child, right? So we see close to 20% saying that they received 5,000 or more. We also see some amount of mistargeting here, showing that close to 5% second-borns have also responded saying that they have received some amount of 5,000 money in their bank accounts. So it does show that the program was successfully rolled out. So there are enough beneficiaries in our sample to undertake such an evaluation. This is the methods slide. This is too much, but then what I want you to understand here is, so what we have is a baseline, which is 2015, 2015, which is our NFHS 4. We have an end line 2019. And in between that, we have an intervention, a maternal cash transfer program that was implemented in 2017. So we have a very nice, natural, quasi-experimental design. What we also have is, we have, so what we did is we undertook a triple difference model. So if you want to understand what a triple difference model is, so first we differenced out people who received cash transfer and people who didn't receive cash transfer. But then obviously somebody might come back and say that there are people who selectively go for cash transfer programs. There are people who opt out because social stigma, they don't want to go through the hassling of filling out forms, standing in queues. So that would bias your results. So that's why what we do is we have the difference of people who receive cash transfers and non-beneficiaries. We also have this nice experiment that the government itself did, where they gave only the firstborn the money, but not the secondborn. So what we have is a difference of firstborns and secondborns. So this is the first difference, and then we have the second difference. So what we are doing is we are differencing out the people who received cash transfers and not cash transfers versus the firstborns and secondborns. So once you difference out the differences of these two, what you end up with is a non-biased estimator. So that's all this is. And then what we also did, we ran some parallel trend tests to ensure that our results are not biased by pre-intervention period. So that's all the method. I didn't go into the much technicality of it because I'm short on time. But then, okay, so the first point, what we see here is what you see here, the gray bar graphs are the number of beneficiaries that were reached by the program. So what you can see here, when the program started, they could only reach around 26%. By the time 2019, 2020, we could see 63% of the targeted population was able to reach by the program. The red, so the program is somewhat able to reach the beneficiaries, but then obviously we would want 100% of people to reach to be able to avail this program's benefit. But you also see the red dotted lines, it's essentially how much government is spending per target beneficiary. So what you're seeing here is what's the money that the government is allocating for number of people who are supposed to get benefits from this program. What you see is around 2,900 rupees, peaking at 2,900, which shows that government is not allocating enough money for the program. Okay. The next is the green dotted line, which you see is even if those who got the money, how much did they get? So what we find is at max around 2019, 2020, people got close to 5,000, but in the preceding or in the successive years, people haven't received the full amount. Okay, so this is the result of our first argue where I talked about what happens to the anthropometric outcomes of the beneficiaries. So by anthropometric outcomes, we have taken two broad anthropometric outcomes, WAS and HAS. So WAS stands for weight for age Z-scores, HAS stands for height for age Z-scores. So if somebody is not aware, if I want to translate into a layman term, what it would mean is relative to your sex and your age, what is your weight in the reference population? Okay, so that's the WAS part, and then the same definition goes for the HAS. What we find here is that both for the adjusted and the unadjusted model, beneficiaries who receive the cash transfer, their firstborns have done better compared to non-beneficiaries. Okay. When we did this across a heterogeneous analysis, we also found that when departments are same at both center and the state, the effects have effects increase, and the rural people have benefited more compared to urban. In terms of pathways, what we find is the conditionality that I mentioned at the very beginning are the ones that are working. So people with beneficiaries have higher likelihood of undertaking pregnancy registration, ANC, and immunization compared to non-beneficiaries. Lastly, what we also that was the RQ2, and this is the RQ3, where we see is that for every 1,000 rupees that the government is spending, we see a reduction in stunting and underweight by 0.27 and 0.35 percentage points. So we do indeed see that the money that you spend end up resulting in broader indicators like stunting and underweight. And we use this. So we use this. I'm just finishing. We use this to calculate a cost benefit analysis. So what we do is the coefficients that I just mentioned, right? Like for every 1,000 rupees, what's the government is getting in return in terms of reduction in underweight and stunting. So we went ahead and developed a cost benefit analysis model to understand what's the outcome that how much is government getting back. So I'll not get into the modeling of it, but then the broad two benefits that we found was for every 100 rupees that the government is spending in the short term, it is likely to receive 138 rupees back. We also see that the government that is spending leading to some DALIs being averted, and that DALI is approximately 31% of GDP per capita. So coming back to the three broad questions that I had posed at the very beginning, what we find is that because of this program, we see improvement in anthropometric outcomes of the beneficiaries. We also find that the conditionalities through which the government has imposed the program is working through those. And we obviously find that the program is quite cost effective, leading to some of the broader implications for other South Asian countries which have or are thinking of implementing similar maternal cash transfer programs. Thank you.
Thank you, Shamudit, for your presentation. Especially, it's a flagship program. We are all aware that this program, the cash transfer program in India, it's a flagship program. So I may have one or two questions in the question answer session. But let's start our third presentation by Ms. Sidratul Muntaha Ikrar, a student of Department of Economics, Jahangirnagar University. She's online. Oh.
Assalamu alaikum. This is Sidratul Muntaha Ikra. Today I am going to present this paper on does government health expenditure contribute to health outcomes and investigation in the South Asian countries. This paper is co-authored by Sadia Afrin, Tazneen Tanha, who are also students, Department of Economics, Jahangirnagar University, and Khaleda Akhtar, Assistant Professor, Department of Economics, Pabna University of Science and Technology. From this study, we can understand the effectiveness of government health expenditure on various health outcomes in South Asian region, and therefore the findings can provide us with some insights which we can apply while implementing policies. The objective of this paper is to evaluate the role of government health expenditure on various health outcomes in the South Asian countries, and this paper then tries to give some justifications based on the findings. Here's the relevant literature. If we look at the slide, we can see that the effectiveness of government health expenditure on various health outcomes is a subject of debate. If we look at the column of findings, we can see that while some papers found significant impact of government health expenditure on health outcomes, but some papers found that there is no significant association between them. As for research gap of the paper reviewed, from this slide, we can learn that previous works focused mostly on life expectancy and infant mortality rate as health outcomes because data of these two variables were available. But life expectancy cannot be a good measure of health since, as we know, a disabled person can live longer than a healthy person. Therefore, to incorporate years lived with disability due to disease and or other injury, one might introduce healthy life expectancy as a measure of health outcome because it takes into account years lived in less than full health. But very few works have been done using healthy life expectancy. In our paper, we have taken three models with three dependent variables. If we first look at model 3, we can see that we have taken healthy life expectancy as a dependent variable. We have taken infant mortality rate as another dependent variable, and we have also taken life expectancy at birth. The rationale of taking life expectancy at birth as a dependent variable is to check the consistency of the result with that of healthy life expectancy. This slide shows the trends of our dependent variable that we have taken. If we first look at the first two graphs, we see that life expectancy at birth and healthy life expectancy at birth both follows upward trend, where infant mortality rate follows downward trend in all the South Asian countries as we expected. Now for methods and instrument, we have employed panel data analysis for 2000 to 2020. And for dependent variables, we have taken real GDP per capita as income is a determinant of health outcomes. And we have considered governmental expenditure, percentage of current health expenditure, as we have already said that. And we have also considered trade openness percentage of GDP. The rationale of taking trade openness is that openness to trade might help to have better healthcare facilities. And we have considered education index from HDI as a social factor, and as an environmental factor, we have included carbon dioxide emission. And in all these independent variable, government health expenditure is our prime variable, and other variables are our control variables. Next, we employed panel fixed effect and random effect model. Then we did Hosman test to understand which model is more suitable for our analysis. Then we did Pesser CD test for checking cross-sectional dependence. And as we know in panel data, the presence of cross-sectional dependence may lead to biased and inconsistent estimator. So the detection of cross-sectional dependence is a must in panel data. And then we did Ulrich test and modified wall test for checking the presence of autocorrelation and heteroscedasticity respectively. Then lastly, we employed FGLS regression. Now let's move to the results and discussion part. This slide shows the result of the fixed effect model and random effect model. But when we do the Hosman test, and if we look at the probability value, we can see that Hosman test suggests that fixed effect model is more suitable for our analysis than random effect model. And Pessaran CD test and its probability value, which is much higher. So we cannot reject the null hypothesis, and therefore we state that there is no cross-sectional dependence in our models. As for heteroscedasticity, the modified wall test and the probability value, which is almost zero. So we rejected the null hypothesis and therefore conclude that heteroscedasticity is present in all our three models. Ulrich test and its probability value, if you look at the slide, we can state that we cannot reject the null hypothesis, and therefore there is no autocorrelation in the models. Now, this is the summary of the results. And this slide shows that in our models 1, model 2, and model 3, there is no cross-sectional dependence, nor there is any autocorrelation, but heteroscedasticity is present in all the three models. Then we employed FGLS regression for our heteroscedasticity panel, but panel with no autocorrelation and no cross-sectional dependence. And if we look at the result, and if we look at the second column, which reflects our first dependent variable, the infant mortality rate, we can see that all the 5 independent variables significantly influences infant mortality rate. And if we look at governmental expenditure, we can see that 1% increase in governmental expenditure reduces infant mortality rate by 0.19%. And if we look at the results of the healthy life expectancy, another dependent variable, we see that all the independent variables influences healthy life expectancy significantly, except for governmental expenditure. Governmental expenditure cannot influence healthy life expectancy even at 10% significance level. And this result is the same as that of life expectancy. Now, our results suggest that government health expenditure has no significant impact on healthy life expectancy and life expectancy. This might happen due to the presence of informal payments, bribery, absenteeism, which is very common in the healthcare sector of South and South Asian countries. And as we know, healthy life expectancy and life expectancy may depend on many other factors other than healthcare factors such as diet, lifestyle, food habit, physical exercise, marital status, etc. Another of our finding is that government health expenditure significantly influences infant mortality rate. This might happen due to the Millennium Development Goals, and as we know, all the country were asked to fulfill these goals by 2015. And if we look at the fourth and fifth goals of the Millennium Development Goals, we can see that the fourth goal was about reducing child mortality, and the fifth goal was about improving maternal health, which might have an impact on the infant mortality rate. As for our recommendation, if we look at the OECD average government health expenditure, which is 65.69% of current health expenditure, but in South Asia, this percentage is 34.55% in 2020, according to World Bank. So we can conclude that government health expenditure is too low in South Asian region to influence the health outcomes. Therefore, government health expenditure has to be increased in this region. Secondly, improved quality of government healthcare services has to be ensured with proper governance. And lastly, with proper transparency under supervision of concerning authority, government budget allocation for health sector must be spent. This paper has some limitations like other papers. We have omitted Afghanistan and Bhutan due to data unavailability, and future researchers can consider quality of government health expenditure along with the quantity, and they can employ different models to see if new insights are found. Thank you all.
Thank you, Muntaha, for your excellent presentation. And our last presentation is, I guess it's an online presentation. It's by Ms. Sachini Gitanjali, lecturer, Department of Political Science, University of Peradeniya, Sri Lanka. And she is going to present her paper on discourse of the space identity of poverty and social protection in urban space.
Hi everyone, am I audible? What happened to me? Problem হচ্ছে এই কাজ উনি করবে রাইট, তো আপনি মেবি স্ক্রিন শেয়ার অফ করবেন না? আমি স্ক্রিন শেয়ার অফ করেছি, না হলে উনি স্টার্ট করতে পারতেন। You are audible. Okay. Shall I start? Right. Most probably. There's some technical difficulty. Can you please wait for 1 minute, please? Okay. Can you please? Can you stop sharing and start sharing it again? Okay, okay. You can start. Okay.
This system has what forces, not only.
Yes, yes.
See, it's working. Just minimize this.
Thank you so much, madam.
Minimize this and go to Zoom.
Okay, thank you. Sachin, you can start.
Okay, thank you. Good evening, everyone. I'm Sachini Gitanjali from Department of Political Science, University of Peradeniya. Today, I will be delivering a presentation on my research paper title is Discourse of the Space Identity of Poverty and Social Protection in Urban Space as the Study of Urban Slums and Shanty Dwellers in Colombo District, Sri Lanka. Now we are moving to content page. Firstly, I would like to present introduction, then research methodology, after that results and discussion, then conclusion, and finally I will be presenting my references part. So, over the last decade, there has been a growing emphasis of utilizing social protection on policy framework to tackle poverty and vulnerability in developing nations. According to the United Nations data, 25% of urban residents worldwide live in slums or informal settlements, posing complex social protection, social, economic, and political challenges, especially in developing countries. So various programs have been introduced for aiming social protection and poverty in urban space, even though the problem is that social protection is structured into the urban space. In that case, the main research problem is why is the urban space consistently excluded or marginalized from social protection schemes and poverty alleviation programs despite the implementation of various social protection initiatives through the intervention of the Sri Lankan government. So when we are discussing about the research objectives, firstly, it is expected to study the space identity represented by the social protection programs operating in the urban space, as well as the political and economic relationship and bias within the social protection programs. And also the extensive exploration is geared toward unraveling the political, economic, and social facets embedded within the structural framework of spatial organization. So, when we are discussing about my research methodology, data will be collected through the qualitative and quantitative methods in urban areas, Mattakkuliya, Hatewatta, and Demetagoda Vanathamul in the Colombo district, and also rural areas, specifically covering the Monarakala district, focusing on social protection process for comparative study. So the research sample comprises 80 respondents selected through the random sampling method. Research methods such as participatory observations and focus group discussions are utilized to gather data in the research areas. When we are discussing about the secondary data has gathered from books, research articles, academic journals, and also central bank reports in Sri Lanka. So you can clearly identify the variations of research sample utilizing this research sample table, and also theoretical approaches employed include concepts such as Henry Lefebvre abstract space and social space, neoliberalism, capitalism, and social sustainability. When we are moving to the results and discussion, so first categorizing slums and shanty dwellers as permanent resident poses challenges as most respondent is struggling to provide proof of residences. Permanent resident is a key requirement in programs like Samruddhi Beneficiary Scheme, Kidney Allowances, World Aid, and Plan Sri Lanka aim at social protection, including children. Space, a primary factor, excludes them from social protection, akin to everyday life colonization by capitalism. So, in that case, Henry Lefebvre mentioned that through the concept of the production of space. Actually, social space is theoretically classified by class structure with allocation reflecting socio-economic disparities. Spatial inequalities in social planning often result from this structure, driven by scarcity principles in the political economy of space. So you can clearly identify environment of the settlements or houses in mainly these two urban areas. So first two pie charts explain that the environment of the houses in both research field. So while when considering the Mattakkuliya urban space, most of residents have lived in houses that has provided by the church, and the second most percentage related to the unauthorized construction and settlement. Then we are moving to the Vanathamulla urban space. Most of residents have lived in flats, and also the other most percentage have lived in rental buyers. So through that, we can clearly identify they haven't the right to the space and also right to the city. It's already connects to the social protection schemes directly. It's evident that the social space in which urban people live is classified and marginalized. It's called as abstract space. So, when considering Sri Lankan election period, during elections, political authorities influenced by the capitalist economic system provide temporary benefits such as money and food packets instead of implementing social security schemes in urban areas. Capitalist economy gives it the full support it needs because of the intrinsic value of urban space. As a consequence, the relationship produced and reproduced through space are crucial political issue. So that Henry Lefebvre mentioned that it's space not only a social space, actually it's a political product. Nonetheless, the main challenge here is the existing patron-client relationship between Sri Lanka's electoral politics and capitalist economic system. For that reason, social protection policies and programs are structured around that relationship. Actually, social protection programs crucial for establishing social sustainability in urban areas continue to marginalize these regions. Political authorities exert control over these spaces, minimizing the relevance of permanent residents in elections. Now, we are moving to my conclusion part. You can clearly identify this framework explains that impact of space on social protection and poverty among urban slums and shanty dwellers. And also, it implies that space identity influences inclusion or exclusion through social protection programs and implies political and economic variables impact on poverty. In that case, correspondingly, it can be finally concluded that informal or irregular settlement, the urban space influence the challenges of social sustainability. The intensity of that influence is determined through hegemonic forces controlling spatial identity. It's a need of the time to prepare a system, program, or scheme in a way that ensures equality, not just sustaining the spatial identity to political and capitalist consuming methods or systems. So you can see my references page. Then thank you very much for giving me this valuable opportunity. And if you have any questions, I would like to answer them. Thank you very much.
Sajini, please stay with us for a few more minutes. After the discussion session, you'll face some question answers maybe. Okay, I now request Nafis Iftikhar to start. He is the discussant of the session and give his comments on the 4 papers presented already.
Thank you, madam, for giving me the floor. First of all, I will start saying that there is some comment. Maybe it's due to the lack of understanding of me. Consider this that a comment from a general reader, so that you can improve your paper. So I'm first coming to the first paper. No, I might change the sequence because I think the paper on the benefit from Pradhan Mantri Matri Yojana program, right? So I really found that the way the paper was presented was very nice. It was in sync right from the beginning. But from the methodology, I have some comments. I can see that you have used 2 rounds of data. That is one from 2015 and 2019. And the logic is the program was launched in 2017. And in that we will have some before after comparison. But the problem is in the main paper, you say that there is no identifier of that particular program, right? So there is an identifier that whether the household received any kind of cash transfer program or not. You are use that identifier as a course. And as you mentioned, that there are so many other cash transfer programs, and you are saying that the estimated effect is for that particular program is questionable. And again, The other cash transfer program was initiated way before 2015. So assuming 2015 as a base year might be confusing also. Then coming up to your second comparison group, the second child of the family, from the logic that Pradhan Mantri Matri Bandhana Yojana gives benefit only for the first child, then the problem is, what is our expectation? Expectation is that we are giving benefit during the first child. They are practicing some good health practices, and they continue to keep the knowledge also for the second child. So second child as a control, that is also a confusing for me. So what you can do, as you have said, that you have a data showing that what is the amount they receive as cash transfer, which is 5,000, or because this particular Pradhan Mantri program gives a benefit of 5,000 taka, which is lower than all other programs. So if you use that identifier, you can pinpoint the identifier of that particular program, and which will give you a better result. And the other part, I have seen your main paper that the discussion part is weak. You can add some more literature and compare the literature. So that's all from the first paper. From the second paper, which is, I think, is there any Kuznets curve on disease burden, NCD related disease burden, right? So I found it is a good academic practice, but there were some limitation in the main paper. First of all, you in the background section, you must write the main motivation of the paper. What is the benefit of finding such analysis? Because many policymakers want to know, if we find this association, what do we do with that? Again, I can see that in the background section you stated your objective or research question. I can see the research question in the title, but you also need to add that question in the background section. And for the estimation process, I thought that you have that you have used all the right methods, but as you are trying to identify the inverted relationship between economic growth and this burden, so using level form will give you a clear idea. And in some part, while you are interpreting the marginal effect, in the regression, you have two terms of permittivity. One is linear form and other one is quadratic form. And you have interpreted separately the marginal effect. But you should understand that the marginal effect here is non-linear. So you should focus on that. And the other thing that there could be some simultaneity between disease burden and economic growth, because you know that disease burden may also affect economic growth. High disease burden may be loss of productivity, and that leads to lower productivity. So in that case, you can use IV estimator or panel genome estimator with an option R. That means you can use the loss system value so that you can take care the presence of autocorrelation on heteroscedasticity. Then for the next paper, which is the effect of government expenditure on health outcome, right? Health outcome. I found that paper maintained all the academic structure. It was rightly mentioned its motivation, the objectives. Also in the literature part, you have rightly mentioned the knowledge gap of other period studies and how we'll fill in the gaps. That's absolutely fine. And just one thing, in your test of autocorrelation, when we accept a null hypothesis, we expect that the p-value should be high, which is not the case in your test result. And in model 2, the p-value was 8. That means you can reject the null. That means that model suffers from autocorrelation. So you can check that also. And similarly, you can also try panel genome estimator and check whether you can get similar result or not. That would be better for you. And the last paper, that is the spatial discourse of spatial, the title,
Space identity.
The space identity of poverty and social protection in urban space. I find that paper pertain to be some field of political science and sociology, and being a background of economics and health economics, it's a bit challenging for me to give commentary on this paper. especially when the analytical framework is based on some specific theory like space theory or the pattern client relationship theory. But I have some comment on methodology section here also. Here, the author mentioned that both quantitative and qualitative technique was used. But in the methodology section, I didn't find this discussion on quantitative section. Other than that, the same FGT group are were also surveyed. And even for the FGT, I found that only beneficiary was interviewed. In my sense, the other stakeholders should also be interviewed. For example, the local and political leaders or the government employees who are responsible for implementing such social question program or this kind of program. And in the findings section, I see some interesting finding, but in my sense, it is always difficult to analyze the quality funding and represent it in a reader-friendly way. But I think author can analyze the quality funding in some thematic areas, which was mentioned in the analytical framework. This will make the paper or finding section more reader-friendly. So that's from my side now. Thank you, Madam, for giving me the floor. Now over to you, the Honorable Chair of the session. Thank you.
Thank you. Thank you so much.
Thank you, Nafis Iftikhar, for your comments. And now I open the floor for question, but I request each one, whoever questions have questions for the presenter to be very brief and should not take more than 1 minute for the question. Please. Any question? Should we go paper-wise? Do you have any question? Anyone? No questions? Yes,
Not a
please.
question answer, but I was wondering, like, when you are trying to see the relation between, thank you. So what I was wondering was, there should be some controls in your regression. I mean, why exactly development and this thing is related? There could be some, maybe some exogenous announcement by the government that something is bad, that's why this is happening. How are you catering to this particular aspect of in your research?
একটা mic দিলে ভালো হতো।
In our study, we tried to show the relationship between economic growth and disease burden. So, as the discussion said, that disease burden also affect economic growth. And here in our paper, we mainly tried to see how economic growth affects disease burden. As we see in environmental Kuznets curve framework, when economic grows, environmental pollution also rises. And when economy develop further, then people or government can pay more to improve their environmental quality, which is an important factor for NPD.
So that's one challenge. What the point was growth being constant. Suppose the government announces like maybe cardiovascular development has happened or something of that sort, and that is causing down and not your economic growth. How will you answer the question?
Well, if economic growth is consistent, then there might be some initiative to improve health outcomes and improve health outcome facilities. So government must invest in those sectors, and to invest there might could be some to invest, government might have some reasons to invest in that. And in health Kuznets curve, we see that when economic grows, so then people, government's capacity to spend for health sector also increases. So from my perspective, I can say that economic growth is important for health outcomes.
Any more questions? Well, I request some questions from you because there were 4 papers, and I guess most of you are students. You may have questions. Please ask. The presenters are here. No questions at all? Okay. So if you're not having any questions, so in that case, I'll have to summarize and end the session. So we were here today for this session, health and social protection. The presentations were 4 papers. Those were all related to either health or social protections. I won't go into much detail of those papers, but the first paper that was on Kuznets curve and its application in the health sector was very interesting. As a student of economics, we are all aware of the Kuznets seminal paper, which actually is a way of showing that how income inequality should first rise and then decline with economic development. As you have applied to this in the health sector, in the presentation, we learned that although the present economic growth is, as you have stated, that present economic growth is positively associated with the burden of NCDs, high economic growth will reduce the burden. But the question is, what is the have to wait for that level of income to reach? Okay, that was my question, but I don't want you to answer the question right now. I think this needs much more research to answer this question. For the PMMVY, the flagship program of India, I would say the rightly address the critical need for maternal nutrition and during pregnancy and the lactation by providing direct cash transfer. These were, I guess, if I'm not wrong, those were conditional cash transfers. This initiative contributes immensely to improving the health of the mother and the child. And if we talk about the Bangladesh context, Bangladesh faces similar challenges in maternal and child health because 36% of our children below the age of 5 are stunted and maternal nutrition remains poor. From getting evidence from this paper, we can always apply this, but we do have some conditional cash transfer program. Those were initiated by USA, and we all know the project is named as Navojatra, and the evidence says that yes, as we have already found in the paper presenters, that the nutritional status of the child and mother is improved due to this cash transfer program. So we can follow that. And for the third paper, where the presenter showed the nexus between government health expenditure and health outcome. So this was a very good economic paper, but in line with those, yes, GDP per capita should increase. We should increase the health sector budget and increase the utilization of the allocated budget, because we all know the mostly around 20% of the budget remains unutilized, and this utilization should be efficiently done. And the most important thing to achieve USC, we need to think about our out-of-pocket expenditure, which is very, very high. And for the last paper, this one, as our discussant Nafis Iftikhar already has mentioned, that actually this was, I'm also a background from economics, so paper from political and social aspects are a little bit different from us, but Sri Lanka and Bangladesh, we both share some common challenges in addressing the urban poverty. The phenomenon of urban slum is not unique to Colombo, but this extends to Dhaka and other mega cities of Bangladesh as well. And globally, all are facing the same. The spatial identity of poverty in urban areas is a complex thing in both Colombo and Bangladesh urban landscape. We witness the marginalized communities being pushed into peripheries, both geographically and socially, and these are the challenges. But way of to answer these problems, to face these challenges, answer could be, as it is mentioned in the paper, we can, the answer could be a social protection program to face these challenges. And with this, I would like to end this session. And lastly, I would like to thank all the participants and the presenters of this session, and of course, the organizers of the conference for the sessions. Thank you. Thank you all. Thank you. Thank you.
Thank you so much, everyone. We have some souvenir and certificates for the participants. I'd request the present chair to hand over the certificates to the participants. So I will take the
Okay, Siddharthul Mundhaika. Sorry. Thank you. Okay. Next is Pfizer Shaheen.
Welcome.
Oh, accepted. Right.
Okay, thank you.
No.
Thank you.